Welcome to this video on pulmonary edema and hemorrhage, neonatal emergency, recognition, and management. We will cover a case scenario, the pathophysiology of pulmonary edema and hemorrhage, and a stepwise management plan. Presented by me, Dr. Salm Keshba. Let's begin with a case scenario. A 28-week preterm infant suddenly deteriorated on day 3 of life with pink-red frothy secretions and spiking ventilator pressures. Blood gas showed severe respiratory and metabolic acidosis. CXR showed diffuse bilateral haziness and fluffy opacities. What is the diagnosis and immediate management? The most likely diagnosis is pulmonary hemorrhage. The mechanism often involves a left-to-right shunt through a patent ductus arteriosus, increasing pulmonary capillary pressure, leading to hemorrhagic pulmonary edema. Pink-red frothy secretions are the cardinal clue. Immediate action includes increasing PEEP, oxygen, careful suctioning, confirming ETT position, treating coagulopathy, and considering an echocardiogram for PDA. Pulmonary edema is the accumulation of fluid in the interstitial and alveolar spaces, impairing gas exchange. The two major mechanisms are increased capillary permeability and elevated hydrostatic pressure. Common neonatal causes are cardiac, such as PDA, and pulmonary issues like severe RDS or pneumonia. Iatrogenic causes include fluid overload or blood transfusions. Clinical signs of pulmonary edema include tachypnea, grunting, retractions, decreased breath sounds, and fine crepitations. Investigations typically show hypoxia, hypercapnia, metabolic acidosis on blood gas, and diffuse haziness on CXR. Important differentials include pulmonary hemorrhage, severe RDS, pneumonia, and air leak syndrome. Management of pulmonary edema focuses on respiratory support, such as optimizing PEEP to recruit alveoli and oppose fluid transudation, and titrating FiO2. Avoid excessive peak pressures. Supportive measures include diuretics and fluid restriction to achieve a negative fluid balance. Treating the underlying cause, like medical or surgical closure of a PDA, is essential. Remember, fluid balance is critical, and diuretics are supportive, not curative. Pulmonary hemorrhage is a rare, life-threatening emergency, often hemorrhagic pulmonary edema. Pathophysiology includes increased pulmonary capillary pressure, leading to protein-rich fluid, and red blood cells leaking into alveoli. Key risk factors include extreme prematurity, PDA, surfactant administration, coagulopathy, hypothermia, and asphyxia. The cardinal clinical sign of pulmonary hemorrhage is pink-red frothy secretions from the ETT, combined with sudden, rapid deterioration. Other features include acute rise in ventilator pressures and signs of shock. Investigations must include urgent blood gas, FBC, coagulation screen, CXR, and an echo to assess for PDA or cardiac function. The management of pulmonary hemorrhage is a stepwise process. Immediate steps focus on securing the airway, increasing oxygen to 100%, and increasing PEEP. Respiratory management involves further PEEP optimization and early consideration of HFOV. Hemostasis includes FFP, platelets, cryoprecipitate, and vitamin K. Finally, investigate and treat the underlying cause, such as PDA, pulmonary hypertension, or sepsis. In the immediate 0 to 5 minutes, time is critical. Secure the airway by carefully suctioning and reintubating if necessary. Increase FiO2 to 100% and rapidly increase PEEP by 2 cmH2O. This tamponades bleeding and re-recruits the lung. If tidal volume is low, increase PIP. Establish IV access, and call for senior help immediately. Ventilator optimization involves a PEEP strategy of 7 to 10 cmH2O. For conventional ventilation, target a tidal volume of 4 to 5 milliliters per kilogram and a rate of 40 to 60 BPM. Consider HFOV early if conventional ventilation fails, especially with persistent hypoxia or bilateral whiteout. HFOV offers superior lung recruitment and lower peak pressures. Correcting coagulopathy is vital. Assess bloods and target platelets above 50,000 and fibrinogen greater than 1.0 grams per liter. Blood product support includes FFP for prolonged PT-APTT, cryoprecipitate for low fibrinogen, and platelet concentrate. Additional measures include vitamin K, cautious use of tranexamic acid, and epinephrine via ETT for local vasoconstriction. Investigating and treating the underlying cause is the next step. For PDA, use an echo to confirm and consider medical closure with indomethacin or ibuprofen, or surgical ligation. If pulmonary hypertension is present, use inhaled nitric oxide. For sepsis/DIC, obtain blood cultures, start broad-spectrum IV antibiotics, and treat DIC with blood products. Surfactant is controversial, but may be considered after stabilization if SpO2 improves. Ongoing monitoring includes frequent SpO2 checks, hourly blood gas, and continuous heart rate and blood pressure monitoring. Ventilator weaning should prioritize FiO2 first, then slowly reduce PEEP. Avoid rapid PEEP reduction. In special situations, like no improvement in 30 minutes, prepare for retrieval to level 3. Refractory hypoxia requires ECMO referral. Be honest in family communication about the significant mortality risk. To summarize the management algorithm, recognize with pink/red secretions. Immediately suction, use 100% FiO2 and increase PEEP. Respiratory optimization follows, aiming for PEEP 7 to 10 cmH2O and considering HFOV. Correct hemostasis with blood products. Identify the cause with echo and blood tests, treating PDA, PAH, or sepsis as needed. Monitor closely and escalate care if required. Early, aggressive management is key to improving outcomes for this high-risk condition. In summary, pulmonary edema is characterized by fluid in the alveoli, with PDA as the most common neonatal cause. Management includes PEEP, FiO2, diuretics, and treating the cause, with an echo being essential. Pulmonary hemorrhage is life-threatening, requiring immediate PEEP increase, aggressive coagulopathy correction, and early treatment of PDA, often needing HFOV.